Hello, we are here to talk about decreasing risks of surgical site infections in cardiothoracic surgery. This is part of a series of optimizing outcomes during a healthcare crisis. I'll be your faculty member. My name is CiNPWT. I'm a director of cardiac surgery at Tri-Star Centennial Medical Center in Nashville, Tennessee, and I've been involved in both wound care and surgical site infection prevention for a little over 2 decades. This program is provided by the North American Center for Continuing Medical Education, which is an HMP company. And furthermore, this particular program is supported by an educational grant from 3M Healthcare, the Medical Solutions Division. Our objectives during the program will be, number one, to recognize the impact of surgical site infections and how they impact our patients. We're going to review strategies for setting up your patient for successful discharge, hopefully free of surgical site infections, explore strategies on how to minimize patient readmission, and explore cases and clinical outcomes for closed incision negative pressure therapy over closed surgical incisions. I think we can all agree in thinking back that the standard closure options are still quite good for a vast number of patients. Standard closure techniques for surgical incisions range from simple suture, whether either interrupted, continuous, exposed, or subcutaneous, staple type techniques, which are sometimes indicated in particularly high-risk fields for infection, tissue adhesives, either as a closure technique with methyl methacrylate or an adjunct to help bolster the incision, surgical tapes such as steri-strips, again, either as a closure for the final layer or as a way to bolster the incisional strength, or some combination of all of these. In addition, adjunctive therapies have often been used over closed techniques. These adjunctive measures have included gauze dressings, hydrocolloids, growth factors, sometimes the use of cultured skin or matrices, and then negative pressure wound therapies. Despite all of these techniques, the risk remains elevated for our patients. Despite advances in surgical technique and in the way we manage our patients during the operation, including preoperative optimization and postoperative care, surgical site infection and surgical site complications continue to be a very major source of morbidity and mortality in our patient population. And we all know that complications with incisions can lead to very serious consequences. As we can see on this slide, as many as 700,000 healthcare-associated infections occur each year, and up to 60% of these are surgical site infections that are thought to be preventable. Infections are a common surgical site complication. We know that they comprise 17 to 22% of all healthcare-associated infections, and other complications, if it's not in the realm of an infection, can include things such as a simple dehiscence of the wound, a hematoma formation, or seroma formation. Regardless of the type of complication, all of these impact the recovery and the functionality of our patients. We also know that patients with surgical site infections are 5 times more likely to be readmitted to the hospital and 60% more likely to actually be admitted to an intensive care unit, which we know is a very high-cost center of care. When we think about surgical procedures and those conditions in our patients that can make healing difficult, they're often very obvious to us. However, people who have researched this have found certain factors that are more correlated with leading to complications. These include sternotomy incisions, particularly in obese or poorly controlled diabetic patients, C-sections, open hysterectomies, hip and knee arthroplasties, open reduction of fractures, lower extremity bypass procedures in patients with compromised circulation and perfusion, and renal transplants for obvious reasons with immunosuppression. Furthermore, there are risk factors within those procedures that can also compromise wound healing. When we think these, the list can be very broad, but let me highlight a few that are very commonly indicated. We know that elderly patients particularly are at higher risk. We know that if there's a wound infection in another locale on the patient, remote from the incision that we're operating on, that puts them at higher risk. Certainly a variety of coexistent diseases such as COPD, PVD, can also lead to higher infection rates, as well as poorly controlled diabetes. Smokers are at higher risk, and those patients that are anemic, that are on steroids, that are malnourished, or have other complicating situations such as obesity, liver disease, coexistent malignancy, all fall into groups of patients that are at much elevated risk for wound infections. We know that the economic impact is quite real. These are real dollars that cost our healthcare system and rob us of resources that we could be deploying elsewhere. Wound complications following surgical procedures can in fact be the difference between a service line that can operate profitably or operates in the red. Surgical site infections we know have been associated with increasing hospital stays. They're approximately adding anywhere between 7 to 9.5 more days, incurring tens of thousands of dollars in medical costs. Something simple as a postoperative dehiscence can add over 9 days of extra hospitalization and more than $40,000 in additional charges. And this is even in the absence of an infection. This is just a simple non-union of a surgical wound. We know in America alone that hospital infections and hospital-acquired conditions now cost billions of dollars. In fact, $9.8 billion is a recent number that has been thrown out there. The top 5 drivers of these costs, as you can see again, surgical site infection ranks number 1 in the hospital-acquired conditions, with ventilator-associated pneumonias, catheter-associated bloodstream infections, C. difficile infections, and cavities that are related to urinary catheters comprising the remainder. We know that there are well-established standard protocols, both by the CDC and the National Institutes of Health, that have been designed to help our patients do better. These simple techniques can drastically reduce, in your patient population, the risk of a surgical infection. These guidelines include the preoperative removal of hair with clippers and avoiding shaving, the perioperative at an appropriate time administration of intravenous antibiotics prior to skin incision and in a time interval that is sufficient for appropriate tissue levels of antibiotic concentrations to occur. Appropriate team antiseptic techniques among the entire surgical team, the scrub tech, the first assistant and the second assistant, and of course the surgeon. Surgical technique that focuses on gentle and delicate tissue handling, the avoidance and overuse of electrocautery, appropriate handling of tissues, and appropriate closures. The importance of pre- and post-operative glycemic control, including at times the necessity to infuse insulin to maintain appropriate blood sugars. Maintaining appropriate tissue perfusion in the sense of appropriate oxygenation, as well as normothermia and avoiding hypothermia or hyperthermia, are all important adjuncts in addition to appropriate ventilation, reduction of traffic, the expeditious conduct of operations to help lower the risk for our patients. However, despite all these things, are there other factors that can improve the healing of our patients and improve outcomes? And this is where potentially the marriage of technology along with appropriate utilization of all of those techniques that we just discovered may be able to make an important difference in your patient. That's why this program is designed to focus a little bit of our time on closed incision negative pressure wound therapy. First of all, you might ask, what exactly is this? We know that negative pressure wound therapy has been around for decades, and this was specifically designed to use over clean or contaminated incisions to help drain away fluid, to help clear infection, and to help through secondary attention in an expeditious fashion to heal the wound. However, closed incision negative therapy is designed to be over clean, closed incisions that may have ongoing drainage issues or that may have high risks for hematoma or seroma formation. This is different from traditional open negative pressure wound therapy dressings that you may have used. However, it still utilizes the continuous negative pressure of approximately 125 millimeters of mercury. Well, how does closed incision negative pressure wound therapy work? Number one, it removes fluid through the incisional interspaces that may otherwise percolate and break down the incision or remain in the tissues. Number two, the dressing itself acts like a splint for the skin to help reduce those distracting forces that may cause lateral tension and increase the pressure of the wound to either dehisce, separate, or form keloid. And finally, it's a protective barrier. It protects the incision from external contamination during the time of therapy. For example, in a sternotomy incision, many times the electrocardiographic telemetry cables are constantly dragging across the incision. These cables are often not sterile, not cleaned even on a daily basis, and seriously put those wounds at risk for contamination. So if we look at closed incision therapy, what are some of the potential benefits? Well, number one, as you can see in this picture, there's mechanical stabilization, meaning we immediately are able to reduce the lateral forces and tension and increase appositional strength of the tissue edges. And this has been shown multiple times through bench studies and computer modeling. We've already talked about the barrier component that's so important, particularly when a wound such as a sternotomy wound can be easily contaminated due to components of the patient's diet, other cables or cords, or other things that could contaminate the incision that's exposed. Certainly groin incisions are at high-risk zones for area of moisture to collect and other contamination to occur since it's close to the genitourinary system. We know that porcine wound models have shown that there's an early increase in wound breaking strength and that there's a narrow zone of dermal scar that has also been shown in the animal model that is created histographically when negative pressure therapy is used on a closed incision. Certainly, due to the negative pressure therapy being applied, there's a reduction in edema, and coincident with that, an increase in lymph and blood flow, which may be the reason that we see reductions in seroma and hematoma formations in those wounds that have been treated with closed incision negative pressure wound therapy. Well, how should we think about this therapy for our patients? Certainly, every patient may benefit from it, but in the world of limited resources, how should we approach the application, the utilization of these very specialized dressings to maximally benefit certain patient populations? One strategy would be to define that the patient must have at least 3 of the following indicators to be considered high risk and eligible. We know that elevated BMIs, poorly controlled diabetes, poor nutritional status is represented by low albumin, poor tissue quality is encountered by the judgment of the surgeon at the time of incision, recent infections in other remote areas, the exposure to immunosuppressants such as steroids within 1 week of their operation, or the presence of a patient in extremis requiring high doses of vasopressors with impaired perfusion would likely be those patients that would benefit the most from some sort of adjunctive negative pressure wound therapy. And then I think the importance is once you onboard this therapy, use that criteria above, and then after 6 months, evaluate to see if you're able to reduce superficial infection rates, reduce wound dehiscence, reduce the need to go back to the operating room to address the wound, and the necessity for later utilization of wound vacs, and certainly the 30-day readmission rate. Going back to show some of the modeling and some of the basic science research that has been done, this slide lets us know that through 3D finite element computer modeling, we can see the lateral tension reduction. If you look in the pictograph to the left, this is before incisional therapy. If you look at the black line in the middle of the slide, you can see this is the representation of the suture line, and you can see the red zones are some of the highest tension zones that occur during traditional and standard wound closure. To the right, you can see that we have applied negative pressure closed incision type wound therapy. In that, we have now converted the area immediately adjacent to the dressing to a green zone, which has minimized the lateral tension. And more importantly, if you look deeper into the tissues, we've essentially eliminated lateral tension or markedly reduced it into the mid-subcutaneous tissues. This is an immediate impact that has been clearly demonstrated. Now, if we look to the intermediate term, which is typically when we might see the formation of seroma, we can see through the nanosphere experimental technique that those incisions that are treated with incisional negative pressure wound therapy, they have a much higher nanosphere quantity in terms of lymph circulation when compared to just simple semi-permeable dressings. This increased accumulation in the lymph nodes is suggestive that lymph flow itself is much greater and therefore seroma formation most likely lower. And finally, for the longer term impact, this is represented by histological studies. We know in porcine models that when the incision apposition was increased through the use of negative pressure wound therapy, as you see at both the superficial dermis, but then when you move to the deep dermis, that those wounds treated with incisional negative pressure wound therapy had much better impact in terms of the histology of the wound. And this is simply at 40 days. So we can most likely deduce from this that there's an acceleration of the wound's healing. Well, several years ago, an international multidisciplinary consensus conference was convened to really look at this therapy and try to decide where and when would it be most applicable for patients. This was a 2-day conclave with 12 representative specialties from 5 different countries. There were presentations from each panelist. There was a major and thorough review of all literature related to closed incision negative pressure therapy, and there was an iterative development of a practice algorithm. And this publication was actually finalized in 2017 and published in the International Wound Journal. And the results were that there were 69 literature citations at that time that met the criteria of our panel. There were over 2,200 patients that were considered and reviewed, including from all of the broad specialties such as orthopedics, cardiothoracic, plastics, general surgery, and vascular surgery. These studies were from a multitude of countries, so they were representative of the practices in those locales. And the key takeaway points were that a variety of procedures had closed incision negative pressure wound therapy applied at their conclusion. The most common procedures were those including vascular bypass, particularly in the lower extremities, large plastic soft tissue procedures, sternotomies and thoracotomies, particularly those in the high-risk patient populations, C-sections, and then ventral hernia repairs and large laparotomies. The key clinical takeaways also included there were a wide variety of surgical procedures included in these studies, and they were very complex in their nature. And then furthermore, that the patients in those studies were at high clinical risk due to those patient factors that we had reviewed earlier in this discussion. What was most remarkable was that all patients treated with closed incision negative pressure therapy had lower rates of surgical site infections, lower rates of wound dehiscence, lower rates of incisional drainage, and much lower rates of hematoma and seroma formation. Furthermore, what emerged is that each procedure type carried its own specific risk factor, and those needed to be evaluated separately. For example, in the cardiovascular arena, we know that those patients who had marked obesity, had poorly controlled diabetes, often represented by hemoglobin A1Cs approaching the double digits, had chronic, ongoing, and active tobacco abuse or use, and those that were put through longer, more complex surgical procedures utilizing vasopressors that had elevated ASA classes at the time of intubation and had concomitant steroid use, all were specific patient-related characteristics that would cause higher rates of wound infections and wound complications. When we broke out the cardiac surgical procedures, there were over 1,000 bypass surgeries per million adults that we found in our review, and that surgical site infection after CABG is relatively infrequent, however, but infinitely complex, costly, and very serious. The basic infection rate can be as high as 3%. In some institutions and programs, we have seen rates of 5 to 7%. Mediastinitis, although rare and often less than 1 to 2%, can still be a very deadly entity carrying over a 50% mortality risk. So what does the literature tell us about, now shifting gears, about the sternum and sternal incisions? We know that there are a wide variety of clinical comparative data that's been developed in this arena. We'll look at a few of these and try to ferret out where there may be some utility. For example, when the question is asked, does negative pressure wound therapy have a role in preventing poststernotomy wound complications, we have to look at some of the data that's out there. This is a study by Atkins et al. That looks at retrospectively high-risk sternotomy patients that went on to receive closed incision negative pressure therapy. One option was using a kind of a homemade system with VAC and Adaptic of 4 days, a total of 57 patients, and they found 0 sternal wound infections when the O to E ratio predicted approximately a 6.4% rate. As you can see, diabetes was quite common in their population in over 54.4% of patients, and that obesity was also quite common, present in over 77% of their patients. The other high-risk features, because remember, this was a high-risk sternotomy study, included renal insufficiency, peripheral vascular disease, as well as congestive heart failure, which were all present in up to a quarter of these patients. In addition, there are large numbers of case series. This one by Colley et al. Looked at 10 patients with an expected rate of 15.1%. Again, remember, we would see these high rates in very selective, very high-risk pools of patients. However, with the implementation of closed incision negative vacuum therapy, this author only saw no wound infections at the 30-day mark, saw complete wound healing with an absence of skin lesions, and there were no device-related other complications observed. When we look at Grauhan's study, this is one that looked at all comers. So separate from the 2 prior studies, these are all-comer patients, not necessarily those at the highest risk, that were randomized to either that group that got closed incision negative pressure wound therapy or historical standard of care, which may include standard skin closure. There were a total of 237 patients treated over a 6 to 7 day period after their initial operation, and these were compared to over 3,500 control patients. In the control group, retrospectively, over 3.4% of those patients had infection, which is what we see historically in many groups around the country. However, when closed incision negative pressure wound therapy strategy was utilized, the infection rate was brought down by 2/3 to 1.3%, producing a very significant p-value. This 62% reduction in wound complications in Germany, where this author is from, had a potential cost saving that totaled 60 to 90 million euros. Now I wanted to turn our attention just briefly to a series of cases that we have done with our group, highlighting some of the strategies and some of the features of closed incision negative pressure therapy. The first case I want to present is that of a 67-year-old female who presented with dyspnea on exertion and angina with her activity. Her medical history, as we see here, included a prior cholecystectomy and prior MI. Labs performed on the week prior to surgery revealed a creatinine of 1.6%, thereby documenting chronic kidney disease, stage 3, despite the lack of anemia and a normal hematocrit. Her operation, due to the very complex coronary anatomy, was quite long, and at the conclusion of the procedure, the patient was on moderate to high-dose pressors. This patient, we can see at the conclusion of the procedure, had an incision that was at risk due to the high pressure requirements and the tension due to the obesity. This was a clean, closed surgical incision over which the negative pressure wound therapy was applied. And then you can see within just 10 days, as it's a fairly advanced healing wound, you can see the high pressure zones at the very top and the bottom of the incision have some mild erythema, but are well approximated with no dehiscence and no separation. The next case I want to highlight is a 48-year-old gentleman who returned to the hospital for complex sternal reconstruction. 2 years prior, he had undergone aortic valve replacement by another surgeon. In the postoperative period, his sternum had failed to heal, and in fact, he had sternal fracture and sternal non-union. His medical history did include smoking, a sternal fracture, and a prosthetic heart valve in situ. The patient presented as a larger framed individual, weighing 260 pounds with a BMI of 36. What we see depicted here in these two slides are the application of the negative pressure wound therapy. Due to the extreme and extensive tattooing of this patient and HIPAA guidelines, we cannot show you more than just the midline incision, lest he be identified by his tattoos. But what we can see is that the 14-day mark, the tattoo is very intact, and that the incision is very well healed, and that there's been no dehiscence. Turning to our third case, this is a 64-year-old male patient who had disc beyond exertion and angina with minimal activity. This is, again, a higher risk patient due to many factors, such as very poorly controlled diabetes, very poor preoperative nutritional status with a low prealbumin, had COPD from prior smoking, and an appearance that was much older than the patient's stated age. Additional laboratory workup did document a lower than normal albumin level and elevated hemoglobin A1C, prompting the consult of an endocrinologist, and also indicative of very poorly controlled diabetes. Patients admitting glucoses, in fact, were in the 290 milligram per deciliter range. So this patient underwent surgical revascularization, but at the time of closure, given all of the high-risk features, we thought it was prudent to apply the negative pressure wound therapy system. It was applied for a total of 5 days. At the time of removal, you can see the small ridges formed by the device. You can see there's markedly less edema on both sides of the incision, and importantly, the incision is very well approximated, very nicely healed with no gaps or openings. Case number 4 is about an obese female who had to undergo an emergency quadruple bypass procedure and who at the time of the operation both had very poorly controlled diabetes with elevated hemoglobin A1C values, very poor tissue quality, a very low albumin, large pendulous breast that would put great amount of shear stress and separation stress on the midline sternal incision. This patient was, of course, randomized to have negative pressure wound therapy applied for a total of 6.5 days as an adjunctive therapy to help reduce her risk of wound dehiscence or wound infection. Here you can see the large pendulous breast. You can see that we had to use a larger Prevena type device. It's quite secure. It fits well and had a nice seal formed around the area of her breast creases. Once the vac was removed, you can see that she has a very well-healed midline incision. There's really no separation. It's actually a well-healed scar that's much further along in terms of its healing than in those patients that would not have had this type of therapy. This patient went on to do very well and had no future or further complications. Here I'd like to pause and segue into demonstrating a video of how we apply the actual therapy. This video shows the conclusion of an operation. You can see that the midline sternal incision has been very nicely reapproximated. My assistant has now cleaned the area and wiped it down of most of the skin prep, and now we're applying a new layer of skin prep to allow the Prevena to nicely adhere. Typically, it's a mastosol type compound. One thing you'll have to notice is that the chest drains for this patient have been located slightly more inferior and slightly more lateral than normal, as well as the temporary pacing wire. The next step is then to pick the appropriate size of the Prevena dressing. It comes pre-made in several sizes, but if the incision doesn't fit one of the pre-conformed sizes, then it's very simple to have a customizable Prevena trimmed to the size that would make sense. The next step when employing closed incision negative pressure wound therapy is to make sure that a good seal is formed, that the adhesive is appropriately approximated and stuck to the skin, that there are no gaps or no areas that would form an air leak. All of the adhesive is nicely adherent to the skin, and all of the removable backing has now been removed. The next step is to connect the device tubing to the reservoir tubing. The reservoir tubing is now passed off the field. It's very simply plugged in to the pump component of the closed incision negative vacuum therapy system. Once that pump is now activated, with the activation of the pump, you will see that the closed incision negative pressure therapy system starts to compress and solidify and starts doing its work. This includes reduction of tension on the wound. It includes removal of any serous fluids. It very nicely becomes adherent to the skin and becomes conformed in such a way that there is no leak. This can be easily tested, as you see done here, and the patient now can safely be transported to the intensive care unit. So in these series of cases that in which we utilize at our institution the negative pressure wound therapy strategy, all of our patients had multiple comorbidities. These comorbidities included obesity, diabetes, and hypertension. We saw that mean incision length averaged approximately 16 centimeters, that the average duration of the negative pressure wound therapy was approximately 5.5 days, and we had good follow-up ranging from 1 to 3 months. At time of follow-up, what we found was that all incisions were intact with good reapproximation of the skin. We found that there were no cases of sternal wound dehiscence and that wound infection was not present, and there were really no additional required procedures in this patient population. The takeaways for all of this and for our patients are very simple and straightforward. We know that wound therapies today and prevention of surgical site infections and skin closures have been long established and they're well established routines. However, in the modern era, I think it is very important to consider the procedure that we're putting our patient through. Is this a high-risk procedure or a low-risk procedure? Is this a unique, particularly stressful procedure? This is a usual procedure with usual level of risk. And finally, we have to consider whether the procedure is lengthy or brief. Next, it's important to consider the patient population. Is the patient a high-risk patient with those comorbidities and those features that we discussed and described earlier in this presentation as high risk, or is this a low-risk patient that's young, healthy, and devoid of other comorbidities? And in fact, is this patient have multiple comorbidities that put them at elevated risk versus the average healthy patient? And do secondary factors have a big role, such as diabetes, particularly that's poorly controlled, or prior MRSA or similar infections? Then the final decision becomes, what are the alternatives? Do we just do the usual and the same, or is this the type of patient or the type of procedure or the combination of a high-risk procedure and a high-risk patient that would demand us to do something more and something different to provide a better outcome? And this is where closed incision negative pressure wound therapy has the potential to create a far better outcome than we have seen in these type of patient cohorts in the past. So in conclusion, what I would posit is that negative pressure incision management system may be considered as a viable non-surgical adjunct to place over clean closed incisions, especially in those patients with increased risk of delayed healing or more complex healing, and particularly those patients that have undergone very complex procedures. I sincerely appreciate your attention and interaction in this webinar. I'm now going to open the forum for questions, either sent to us by chat or electronically, and we'll try to go through each of those questions. We'd also very much welcome your comments. Thank you very much. This concludes the presentation.